very long, and we don't have enough time because with the previous group was very, very difficult to teach because the concepts of the class are so many, and there are many basic concepts that you don't know yet because you are in the first year. So some things will be very difficult to explain, but we will try. So today is the last class about bacteriology. The next class will be about viruses. If the university is open next week, we will have the midterm exam at the end of next week about bacteriology. The midterm exam is very easy, and we will explain you on Monday morning how the exam is. We will explain about the questions, and that is not difficult. It's not difficult for you. Anyway, so the midterm exam will be at the end of next week if the university is open. So we are here. Today we are going to study gram-positive bacteria. So we go back to gram-positive bacteria. And we are going to study the last gram-positive rod, aerobic, that is special. Those of you who were in the practice know already about Mycobacterium. Today we are going to study Mycobacterium, the last one. This is the first part of the class, and the second part of the class is Clostridium, anaerobic. Okay, so we start with Mycobacterium. No, sorry, it's not this. This is not the. Wait a moment. We are here. Okay. So Mycobacterium. Mycobacterium, there are many species, and all of these species may be classified into 3 groups. Mycobacterium tuberculosis complex. This is the most important. Complex means that it's not only one species. There are many species, not only one. We will study later. The second one is Mycobacterium leprae. Unfortunately, we don't have time to study Mycobacterium leprae. Mycobacterium leprae is the cause of a terrible disease. Not very common, but we still find cases of Mycobacterium leprae. The name of this disease is leprosy or Hansen's disease. And the last group of Mycobacteria are called non-tuberculous Mycobacteria. Some people call them also atypical Mycobacteria. These bacteria are a lot, they live in the environment, and they are usually opportunistic pathogens. The most important and the only one that we are going to study is Mycobacterium tuberculosis. So look, what about Mycobacterium? What about Mycobacterium? Mycobacterium is special for many different reasons. The most important is because the cell wall contains a lot of lipids, as I told you in the practice number 2. So I go to the whiteboard and we are going to write here why are they so special. So Mycobacterium contains special components in the cell wall. The first, many lipids. The most important lipids, as I told you in the practice, are mycolic acids. The second is lipoarabinomannan. I will show you now in the picture. Lipoarabinomannan. Lipoarabinomannan, LAM. These two are the most important. but they also have others. I go back to the picture. This is the cell wall of Mycobacterium that I show you in the practice. This is the cell membrane. This is the peptidoglycan, thick. So similar to gram-positive bacteria. And this cover, like a coat outside, these are the mycolic acids. And this, in green color, this is the lipoarabinomannan. Because of this cover of lipids, so important, these bacteria are acid-fast positive. Acid fastness, as we told you in the practice, is that bacteria are very resistant to decolorize. They are very difficult to stain, but once stained, they are very difficult to decolorize. That is acid fastness. So I go back to the whiteboard. So many lipids, but not only lipids, they have polysaccharides. These polysaccharides, the most important is called arabinogalactan, but this is not important for you. Arabinogalactan. And finally, they have some special proteins, transport proteins in the cell wall. These transport proteins are important antigens, and they are very useful for the diagnosis of the disease, for the diagnosis of tuberculosis, but this is for later. The name of these proteins, these antigens, is PPD, but this is for later. Currently, the most important to remember is the cover of lipids. Okay? So, in this class, we are going to study only one of these groups of Mycobacteria. We are going to study Mycobacterium tuberculosis complex. Complex means many different, not only one. The most important species of Mycobacterium tuberculosis complex is Mycobacterium tuberculosis. Mycobacterium tuberculosis is only found in humans, only. So look, don't be, to avoid confusion. Mycobacterium tuberculosis complex is not only one species, there are many species. And the most important is Mycobacterium tuberculosis. Another one is Mycobacterium bovis. Mycobacterium bovis is found in some animals. These animals are bovine animals. So this is the cows and others. Okay. And sometimes may be transmitted to humans. So this is zoonosis. Okay. Mycobacterium bovis. And humans may also transmit Mycobacterium bovis to other humans. Okay. Another bacterium that belongs to this complex is Mycobacterium africanum, but this is very uncommon. And others that we are not going to study. Mycobacterium tuberculosis is the most important, okay? The most important related with the disease, with tuberculosis. So look, one thing that we must remember for later is that this bacteria may enter in a latent state, so latency. This is very important to understand the disease later, okay? So I go back to the presentation. Look, this is an acid-fast stain that you already know from the practice. This is an acid-fast stain with acid-fast positive bacilli with red color, red-pink color here, a lot. This is the same acid-fast stain, Schill-Nielsen stain, that we learned in the second practice with red color, okay? This bacteria, the cell wall structure of this bacteria is the same as gram-positive bacteria. However, we can't use the gram staining for this bacteria because of the cover of lipids. The crystal violet or safranin cannot enter inside the cell wall. So what happens when we apply gram staining? This is what happens. If we perform the gram staining, bacteria do not get any color. In some textbooks, people call this bacteria ghost bacteria. These are also ghost bacteria here. Sometimes they appear a little bit purple because the cell wall structure is gram-positive, but we don't see any color. These are ghost bacteria. Okay, so we are going to start with the disease, with tuberculosis. This is Robert Koch that we mentioned in the first class. Robert Koch discovered Mycobacterium tuberculosis 100 years ago, and he discovered that this bacteria is the cause of tuberculosis. Tuberculosis is one of the oldest diseases that affect humans, discovered that by Robert Koch 100 years ago. Tuberculosis is the name of the disease, and this disease is caused by bacteria that belong to Mycobacterium tuberculosis complex. And the most important species and the most common is Mycobacterium tuberculosis. So, tuberculosis, remember, latency. Tuberculosis may affect different organs, but the most common is the lung, the most common. So, pulmonary tuberculosis is the most common. But tuberculosis may be found in other places, like the lymph nodes, or the pleura, or the bones, or the joints, or the kidney, or the brain, many different places. Okay? Tuberculosis is another disease of poverty. Between 95% of cases to 99% of deaths appear in poor countries, in very poor countries. Tuberculosis, the incidence of tuberculosis increased 40 years ago when HIV appeared. So because of the HIV pandemic, tuberculosis increased very much. Currently, the incidence of tuberculosis is decreasing, as I will tell you later. Tuberculosis has a very high mortality. In people who receive no treatment, the mortality is 33% the first year, or 50% during the first 5 years. So mortality is very high. However, good news, tuberculosis can be cured with effective treatment. If we give antimicrobials, tuberculosis is cured. Good news. However, bad news. Currently, tuberculosis is becoming resistant in some places, mostly in Russia, or China, or India, and other places. In Vietnam, it's not very important yet. So this is the problem of tuberculosis now, that tuberculosis is becoming resistant. The transmission of tuberculosis is from person to person, sometimes from animals to person, but for the species Mycobacterium tuberculosis, is only from human to human, through the air, airborne transmission. We explained this when we were talking about Legionella in the last class. So this is not exactly like droplets. When a patient is coughing or sneezing or speaking, they release droplets that you already know. These droplets dry, so they become very small, less than 0.5 micrometers. And these small particles that we call droplets nuclei may spread through the air. So the transmission through the air, airborne transmission, is more dangerous than droplets because these particles are very small, so they can travel a longer distance. Tuberculosis is spread very easily in crowded living conditions. So in poor places where many people are living together in a small house, tuberculosis is spread very quickly, mainly in poorly ventilated rooms. Tuberculosis is very common in the world. About 1/3, this is a lot, 33% of the people in the world are infected. 2 years ago, these are the last data that I have, the deaths because of tuberculosis in HIV negative people were more than 1 million in the world. This is a lot. However, as I told you, in the last 20 years, tuberculosis incidence is decreasing about 2% every year. And mortality has been also falling in the last 20 years. What about Asia? What about Asia? Tuberculosis is decreasing very much. For example, the countries that have showed the most important decrease have been Myanmar and Vietnam. The incidence of tuberculosis disease in Vietnam and Myanmar has decreased very much in the last 10 years. Look, this is tuberculosis now in the world. Most cases of tuberculosis are found in sub-Saharan Africa and Asia. What about Vietnam? Currently, tuberculosis is still one of the most common infectious diseases in Vietnam. You will study tuberculosis in deep detail in the last year of medicine. Currently, the incidence of tuberculosis in Vietnam is about 174,000 people, but decreasing. Look, this is the picture of incidence in Vietnam. Remember the meaning of incidence. Incidence means new cases. This is Vietnam in the last 20 years. The incidence has been decreasing very much. Currently, in the year 2019, the last data that we have from the World Health Organization, the incidence of tuberculosis in Vietnam is around 200 cases per 100,000 people. The incidence of tuberculosis is higher in the south and lower in the north. In the center here, we are in the middle, okay? But we are around 200 cases per 100,000 people and decreasing every year. The problem now in the world is that tuberculosis is becoming resistant. So this is a problem, as I told you, in the former Soviet Union, so Russia and Ukraine and other republics that belong to the Soviet Union, and China and Mongolia. In Vietnam, the rate of resistant tuberculosis is 3.6%. That means of all cases of tuberculosis in Vietnam, 3.6% are multi-drug resistant. Not many, but increasing. Okay, so now we are going to try to explain tuberculosis. Tuberculosis is very difficult to understand because it's a difficult disease, and it's difficult for you to understand because you don't have basic knowledge yet. But I have to introduce tuberculosis because if not, we just learn words randomly. If we are talking about tuberculosis, you must know a little bit about tuberculosis. So I have to introduce the disease for you, okay? So we are going to follow the infectious process from exposure to disease. Not easy, okay? But we are going to try. Just remember latency, because latency is a very important concept to understand tuberculosis. So I go to the PowerPoint, okay? So wait a moment, because I have to open it. Wait a moment, so we are here. Wait. So we are going to study tuberculosis, the infectious process from exposure to disease. So we always start with exposure. Through the air, airborne transmission from human to human, mostly from human to human. And what happens after exposure? What happens? Most of the times, nothing, because more than 90% of bacteria will be trapped in the upper respiratory tract. Very few bacteria will reach the alveoli, the lung. So most of the times, nothing happens. Most of the times, Mycobacterium tuberculosis is eliminated. However, sometimes people may suffer tuberculosis, and people may become infected by tuberculosis. This is called primary tuberculosis. Primary means first. Primary tuberculosis. And what is this? This is infection. So people become infected. What is this? In about 66% of people, so 2/3, in 2/3 of people with primary tuberculosis, these people are mostly adults, they are asymptomatic, so they don't notice anything. However, in about 33% of people, 1/3, they are mostly children, they may become symptomatic. 33% of them. What happens later? What happens later? Most of the times, 95% of times, in 95% of people, Mycobacterium tuberculosis becomes latent. So latency. However, in some people, 5% of people may suffer a severe disease. This is called primary progressive tuberculosis. These people, these 5% of people are usually children or very old people or immunocompromised people. This disease is very severe. This disease may be local, so pulmonary disease, or it may become disseminated all over the body. For example, meningitis. This is very severe. But again, this is not common. This only happens in 5% of people. In 95% of people, the disease becomes latent. So latency. So look, what happens in these people? What happens in people with latent infection? What happens? Some of them, not all, may suffer disease. This is called post-primary tuberculosis. Post means after. So this means after primary tuberculosis. Wait one moment, please. In some books, post-primary tuberculosis is called reactivation. This is disease, okay? So during latency, the bacteria is inactive. That means this is not absolutely true, because in the case of tuberculosis, these bacteria in latency are not absolutely inactive, okay? But we call it latency. In some people, these inactive bacteria may become active again and cause disease. This is called post-primary tuberculosis. In some books, this is called reactivation. How many people? About 10% of people in their lifetime may suffer post-primary tuberculosis, reactivation. However, if these people are infected with HIV, a lot of them will suffer disease, okay? So this is the picture of tuberculosis. In this picture of tuberculosis, we can differentiate two different stages. We can differentiate latent infection and we can differentiate disease. So look. So we are going to study this in a table. Wait a moment. So we are going to study this difference in a table. This one. Wait a moment, because I have to open it. So wait. So we are here. So tuberculosis, we can classify tuberculosis into two different stages. Latency, so latent tuberculosis infection, and the other one, disease. Tuberculosis, active disease, two stages. And we are going to study the differences between them. The latent infection is inactive. However, the disease is active. The latent infection is asymptomatic, so people don't know that they are infected. The active disease is symptomatic. Latent infection is not contagious. However, the active disease is contagious. In people with latent infections, I told you that tuberculosis is mainly a pulmonary disease, okay? A respiratory disease. So, in patients with latent infections, the X-ray is usually normal. Not always, but usually normal. However, in patients with disease, the X-rays are usually abnormal, so not normal. In patients with latent infection, if we take samples and we prepare smears for staining and we culture in microbiology, these results are negative. Can you hear me?
Yes.
Can you hear me clearly?
Yes.
Yes? Okay.
Clearly.
Okay, so I continue. So, in latent infection, the culture and the smears that we prepare for staining are negative. We don't find bacteria. However, in patients with active disease, these cultures, these smears are positive. What else? We will explain later some tests for the diagnosis of tuberculosis, and these tests are immunological tests. These immunological tests are two, we explain later, but I mention now, the tuberculin skin test and the interferon gamma release assay. These tests in patients with latent infections are positive. In patients with disease are also positive. So these immunological tests are not helpful for differentiating latent infection and active disease. And finally, when we say that someone is a case of tuberculosis, we mean that this person is suffering an active disease. So this is a case of tuberculosis. A patient with active disease is said to be a case of tuberculosis, and not this one. This is not a case of tuberculosis. So differences between latency and active disease, differences, okay? So I go back to the presentation. So this is the same, okay? This is the same. So look, many people in the world are infected, many people, but very few suffer disease. So this is another example where we can differentiate infection from disease. The problem is that some people suffer disease. So the problem is to know who is going to develop disease. People immunocompromised, people whose immune system is not working properly, have a very high risk of developing disease. For example, people who suffer AIDS, acquired immunodeficiency syndrome, have a very high risk of developing tuberculosis disease. Very high. This is the worst. This is the people with the highest risk of developing disease. The second one is people infected with HIV, so HIV positive. By the way, AIDS and HIV positive is not the same. One thing is HIV positive and one thing is AIDS. It's different. These people have a very high risk of developing disease. The third group, people with transplants. You already know that people with transplants is receiving immunosuppressant therapy. These people are immunocompromised. So these people also have a very high risk of developing disease. So this group of people is possibly the group of people that have the highest likelihood of developing tuberculosis disease. What about the pathogenesis? We are going to say very few words. Mycobacterium tuberculosis is a facultative intracellular pathogen. You already know the meaning. To fight tuberculosis, the most important part of the immune system to fight tuberculosis is the cellular immune response. The T helper 1 cellular immune response. This is the most important. You remember from the second class. I told you in the second class that these cells, T helper 1, these cells are CD4 positive T cells, and they release interferon gamma. The cytokine interferon gamma is very important to fight tuberculosis. T cells, T helper cells, T helper 1 cells that have been activated by antigens from Mycobacterium tuberculosis are going to release interferon gamma. And this interferon gamma is very important to fight tuberculosis. So look, humans are very easily infected by Mycobacterium tuberculosis. So the infection is very easy. 1/3, so 33% of people in the world are infected, but very few suffer tuberculosis. So we become easily infected. But humans are very resistant to tuberculosis. Easily infected, but very few suffer tuberculosis disease. Mycobacterium tuberculosis produces many virulence factors, but we are not going to study these virulent factors. We are going to study only one. We are going to mention only one. This antigen, the ES86 antigen, early secretory antigenic target, this is a very important protein for bacteria to survive inside macrophages. I told you before that Mycobacterium tuberculosis is a facultative intracellular pathogen. They live inside human macrophages, and this protein is very important for bacteria to survive inside these macrophages. This is the only antigen that we are going to mention, not the others. Tuberculosis, the disease tuberculosis, is classified either as pulmonary tuberculosis, infecting the lung, or extrapulmonary tuberculosis, outside the lung. The most common is pulmonary tuberculosis. We are going to study only some things about pulmonary tuberculosis. Okay, so now microbiology. Now we are going to talk about how to make the diagnosis of tuberculosis. And we are going to study in the table. So the diagnosis of tuberculosis is made at the microbiology laboratory. So this is real microbiology. So for the diagnosis of tuberculosis, we are going to differentiate both stages: the latent tuberculosis infection and tuberculosis disease, both. And we are going to start with tuberculosis disease. So how can we make the diagnosis of tuberculosis disease? So the same as we always do at the laboratory of microbiology, we collect specimens, samples. Because the most important tuberculosis is pulmonary tuberculosis, we collect respiratory samples. The most common respiratory samples is the sputum. For the diagnosis of tuberculosis disease, we must collect 3 different samples, so 3 different sputa, into 3 consecutive days. These samples must be collected early in the morning, so when the patient wakes up. However, some people now say that we can collect 3 samples in only one day, but one of these 3 samples may be collected early in the morning. This is what I explained you in the presentation, and that's enough. So sputum, this is the best, well, not the best, this is the most common sample that we can collect. But we can also collect other samples, like bronchoalveolar lavage. But this is more difficult to obtain. So respiratory samples. The easiest is sputum. However, for children, it's very difficult to get sputum, very difficult. This is only possible in adults. So in children, we can collect specimens from the stomach, gastric specimens. So we perform an endoscopy and we get gastric specimens. We also collect 3 specimens. This is very useful in children, because children swallow the sputum. That is the reason why we can find Mycobacterium tuberculosis in the stomach. So we can get gastric samples. What else? In some patients with kidney tuberculosis, with renal tuberculosis, we can get urine. 1 sample is enough, 1 sample early in the morning. In other patients with disseminated disease, we can collect other samples. Urine, or CSF, or others, bone marrow, many different samples, okay? The most common, because pulmonary tuberculosis is the most common, the sputum is the most common sample that we can get. So these are the samples. So we go to the laboratory with the sample. What can we do at the laboratory? Staining. as always. Gram staining. Yes, the gram staining is not useful for mycobacteria because they have mycolic acids in the cell wall. It's not useful. However, we always perform the gram staining because we are not sure if this patient is suffering tuberculosis or not. So we have to perform the gram staining trying to find other pathogens. So we perform the gram staining always, even when it's not useful for mycobacteria. We perform acid-fast stains. Acid-fast stains. And this is one of the purpose, this is one of the things that we do in the practice number 2, okay? Acid-fast stains, we have two groups. Non-fluorescent stains, non-fluorescent, and here we have studied in the practice the Sill-Nielsen stain that you already know. We have another one, it's called Kin-Yun. The Kin-Yun stain does not require heat, and others, okay? These are the most important. The most common in the world is Sill-Nielsen. Non-fluorescent. Non-fluorescent means that we can use the optic microscopy. We don't need any special microscope. The other stains, acid-fast stains that we can perform are fluorescent stains. For these fluorescent stains, we need a special microscope, a fluorescent microscope. This is only found in some hospitals. And the most common stain is called auramine rhodamine. This is the best, auramine rhodamine. But we have others. I show you a picture later. So staining at the laboratory. In some places, the laboratory of microbiology can perform real-time PCR that you are going to study in molecular biology. And this is very useful sometimes in some places because it's very fast. One of the platforms that we can use for real-time PCR is the Expert Plus platform. This is the name of the brand, okay? The Expert. But it's not important for you. So in some places, real-time PCR. And finally, what we do in the laboratory always is culture. We culture the sample. And we culture in solid media and in liquid media, as always. Solid media and liquid media. We have many. The only one that we are going to mention is the classical one. We are going to mention Lowenstein-Jensen. This is the classical one, but we have a lot. And liquid, we have Middlebrook and others, but we are not going to mention. So the only one that we mention is Lowenstein-Jensen. The culture of Mycobacterium tuberculosis is very slowly because the replication time is very slow. So we need to culture for several weeks. Between 2 to 6 weeks, we need to grow Mycobacterium tuberculosis. This is very different to other bacteria that you already know. For example, E. coli. E. coli can grow in 18 hours. Mycobacterium tuberculosis needs several weeks. So the diagnosis of the diagnosis of tuberculosis by culture is very slowly because we need many weeks. Okay, so this is what we do in the laboratory of microbiology for the diagnosis of disease. Look, this is a fluorescent stain. This is the auramine rhodamine stain. Fluorescent. This is very easy. It's very easy to perform and it's very easy to observe because we observe bacteria that are fluorescent. This is much easier than the Sill-Nielsen stain. The Sill-Nielsen stain is very difficult to observe. Okay, so how can we perform the diagnosis of latent tuberculosis infection? For the diagnosis of latent tuberculosis infection, we are going to use immunological tests. We are going to mention two, but we are going to say more things about only one. So we go back to the table. The diagnosis of latent tuberculosis infection is made by immunological tests. So we detect the human immune response. We don't detect the bacteria. We detect the immune response. And we have two tests here. We have the tuberculin skin test, TST. This is also called the Mantoux method. And this is the most common. We have another one that is less common. The other one is called interferon gamma release assay, IGRA. This is not so common. We will say something later, but not many things. We start with this one. What is this? What is the tuberculin skin test? This is very common. I am sure that some of you already know, because maybe someone has performed on you for diagnosis of tuberculosis. Tuberculin skin test. What do we do? What do we do in this test? We inject some antigens in the skin, in the dermis. These antigens are the PPD that I told you at the beginning of the class. These antigens are proteins that belong to Mycobacterium tuberculosis, and they are found in the cell wall, PPD. So we take these antigens and we inject them in the dermis. And after 2 to 3 days, we check the skin and we check if the skin has reacted. If the skin has become indurated, that means that the skin has reacted against these antigens from Mycobacterium tuberculosis. So we check the skin. I show you the pictures later. We check the skin. If the skin has reacted against them, that is a positive result. If the skin has reacted, that means that the immune system has recognized these antigens and has produced a response against them. So a positive result means a positive test, a positive tuberculin skin test means that the patient has been infected. However, we can't differentiate latent infection from active disease. So a positive test means that the patient has been in contact with Mycobacterium tuberculosis, but we can't differentiate latency from disease, okay? This is the problem. This is the reason why I told you before that immunological tests are positive in both cases, in latent infection and in active disease, in both. So the meaning is the patient is infected. Disease or no, we don't know, okay? So this is the tuberculin skin test. However, this test is not perfect. This test may fail. This test has false positive results and false negative results. False positive results in people that has been vaccinated. In vaccinated people, we have a vaccine against tuberculosis, but we will explain later some things. This vaccine is called Bacille Calmette-Guerin, BCG. All of you have been vaccinated. In vaccinated people, these people may show a false positive result. And we have another false positive reaction in people that are infected with other mycobacteria. In people infected with non-tuberculous mycobacteria. These people may show a false positive result. This test also has this test also has false negative results. This test may appear falsely negative in immunocompromised people. Immunocompromised people cannot react efficiently against Mycobacterium tuberculosis. So immunocompromised people may show a false negative result. And also in people with disseminated disease. These people may show a false negative result. So this test fails in these cases. I show you what is the tuberculin skin test. This is what we do. We inject the antigens. Sorry. We inject antigens in the dermis. These antigens that we inject in the dermis are proteins, the PPD. Okay? And we check what happens 2 or 3 days later. If the skin reacts against these antigens, like here, if the skin reacts, the skin becomes indurated. So the skin becomes hard to touch. So you have to touch, not only to see, you have to touch. If the skin becomes indurated, that means that the skin has reacted against these antigens. This is a positive test. The meaning of a positive test is the patient has been infected. Okay? This is the tuberculin skin test. Like this. But again, you have to touch the skin. It's not enough to see, you have to touch. The other test that we have, is the interferon gamma release assay. This is another immunological test. This is a blood test. So we take blood from the patient. From the blood of the patient, we take T cells. We take these T cells and we mix these T cells with antigens from Mycobacterium tuberculosis. And we check if these T cells release interferon gamma. If these T cells from the patient release interferon gamma, that means that these T cells have been previously activated by Mycobacterium tuberculosis. This is what I explained you in the second class about immunology, and I hope you can remember. So, if the T cells release interferon gamma, that means that these T cells have been in contact with Mycobacterium tuberculosis. So that means that the patient is infected. Interferon gamma release assays do not have false positive results and do not have false negative results. So the test is better. However, this test is more expensive and we need more equipment. So this test is only performed in some situations. The most commonly used test in the world is the tuberculin skin test, this one. The interferon gamma release assay is only done in some patients. So immunological tests, when these tests are positive, that means that the patient has been infected with latent infection or with disease. We can't differentiate. Okay, so I go back to the presentation. So what about the treatment of tuberculosis? We are going to divide also into two groups. So what about the treatment? Patients with disease or patients with latent infection? What about tuberculosis disease? Who should be treated? Who to treat? All patients with disease must be treated. All of them with antimicrobials. Tuberculosis is one of the diseases that you must remember. I mean, you must remember the antimicrobial treatment. We treat patients with a combination of drugs. We treat patients with a combination of drugs. And there are many different combinations, but you have to remember only one. During 8 weeks, so 2 months, we must treat the patient with 4 drugs: isoniazid, rifampin, pyrazinamide, and ethambutol. 4 drugs during 8 weeks. The name of these drugs you have in the presentation, okay? Later, during 18 weeks, so almost 5 months, the patients are treated with 2 drugs, with isoniazid and rifampin, 2 drugs. So we treat patients for a long time. This is the most common combination, but we can use this combination only in places where tuberculosis is not resistant. In other places, we have to use other drugs. The only combination that you have to remember is this one. So the treatment is very long. All patients must be treated. What about latent tuberculosis infection? Who to treat? Many patients are infected. Should we treat all? No. We don't treat all patients. Not all patients with latent infections must be treated, only some. We only treat patients with a high risk of developing disease. For example, patients with AIDS, or HIV positive patients, or patients with transplants, or many others. If you are interested in knowing who are these patients, I explain you very clearly at the end of the presentation in the complements for better understanding. Unfortunately, we don't have time in the class to explain this in detail. Just to tell you that not all patients are treated, only some with high risk of developing disease. Okay, so I go back to the presentation. All patients must be treated. Tuberculosis is a very old disease, and we know tuberculosis for a long, long time. Before antimicrobials appeared, patients were treated with ultraviolet light, as I told you in the practice. This is called sanatorium. Before the appearance of streptomycin, that was the first antimicrobial against tuberculosis. It's the same. Currently, we use antimicrobials. These four are the first line agents against tuberculosis that you must remember. We always use them in combination. And as I told you before, not all patients with latent infection must be treated, only some. Only patients with high risk of developing tuberculosis. These patients with latent infection are treated for 9 months. We can use many different antimicrobials. The most common antimicrobial to treat these patients for 9 months with latent infections is isoniazid. But we can use other antimicrobials. We can use rifampin, for example. But we are going to mention only this one. And to finish tuberculosis, we are going to say a few words about the vaccine. This is the vaccine against tuberculosis, BCG, Bacille Calmette-Guerin. Bacille Calmette-Guerin, BCG, is a live vaccine. It's a live strain of Mycobacterium bovis. It was developed 100 years ago by 2 French microbiologists, Calmette and Guerin. Currently, we have several, not only one. Currently, BCG is the most widely administered vaccine in the world. All of you have been vaccinated when you were babies because because we still use this vaccine in countries where tuberculosis is a very important problem. The BCG vaccine does not protect against tuberculosis infection. So what is this? The protection of the vaccine is about 80% of people in the first 15 years of life. This vaccine protects children, but not adults. The benefits of this vaccine are: this vaccine decreases very much the risk of tuberculosis meningitis in the child and disseminated disease in the child. So the most important benefit of the vaccine is that it decreases the most severe forms of tuberculosis in small children. But the vaccine cannot prevent the development of infection. The vaccine prevents the development of severe diseases, but not infection. Currently, as I told you, the World Health Organization recommends the vaccine in places where the incidence of tuberculosis is very high. For example, in Vietnam. So all of you have been vaccinated when you were babies. Remember, the BCG is a live vaccine. It's not recommended to give live vaccines for immunocompromised individuals or to pregnant women. I explained you this in detail in the self-learning topic related with vaccines. So this vaccine is alive and it's contraindicated in immunocompromised people and pregnant women. Again, the vaccine does not prevent tuberculosis infection. It only prevents severe tuberculosis disease in children. So this is, in summary, what we can do with tuberculosis. We can treat tuberculosis with a combination of drugs that we have explained already. We can vaccinate children to prevent severe tuberculosis. And we can perform post-exposure prophylaxis and prevention of disease. This is the treatment of latent infection with isoniazid for 9 months, but only sometimes. If you are interested, you can check this in the complements for better understanding at the end of the class. And I explain you here in detail who must be treated. What about Vietnam? In the last 10 years, tuberculosis has decreased very much in Vietnam. The incidence of tuberculosis in Vietnam has decreased 3% every year, and this is very good because the Vietnamese government implemented a program to fight tuberculosis many years ago. So currently, tuberculosis is improving a lot in our country. Tuberculosis is decreasing very much because of a national program of tuberculosis. As I told you, the incidence of tuberculosis now is much lower than 10 years ago. A little bit much higher in the south and a little bit lower in the north. Okay, so before we continue the class, do you have any question about tuberculosis, tiếng Anh or tiếng Việt?
Các bạn có câu hỏi gì ở phần tiếng Anh hoặc là tiếng Việt không? Các bạn đặt câu hỏi đi. Tại vì cái nội dung của mình nó dài quá nên cô đánh máy và cô gửi qua cho các bạn hè.
Dạ cô.
Có bạn nào có câu hỏi không?
Cô ơi cho em hỏi là cái thời gian mà lây tần của nó mà tại sao lại lâu như thế ạ? Có thời gian mà ủ bệnh của nó ấy, tại sao mà lại là 5 tháng, 6 tháng không phải là ngắn hơn cô?
Ý là cái thời gian mà từ khi tiếp xúc cho đến khi nó phát triển thành bệnh hay là thời gian mà tiềm ẩn em? Nó khác nhau nghe em, có nghĩa là thông thường khi mà vi khuẩn lây qua đường hô hấp thông qua các cái giọt bắn á, thì nó sẽ có cái tỷ lệ cao là cơ thể của chúng ta có hệ miễn dịch và nó sẽ loại bỏ được bệnh và bệnh nhân hoàn toàn không có biểu hiện gì bệnh và thậm chí là có thể có được miễn dịch với lao. Tuy nhiên thì nếu như trong cái tỷ lệ thấp còn lại á, là bệnh nhân sẽ có khả năng là phơi nhiễm và phát triển thành bệnh. Thì khi phát triển thành bệnh nó sẽ có hai dạng, có nghĩa là đã có vi khuẩn ở trong cơ thể rồi á, thì nó sẽ có hai dạng là một là ban đầu nó sẽ gây bệnh nhưng ở cái yếu không quá nghiêm trọng và vi khuẩn chuyển qua trạng thái như là trạng thái ngủ, có nghĩa là trạng thái tiềm ẩn. Thì ở trạng thái tiềm ẩn đó nó tồn tại rất là lâu dài trong cơ thể của bệnh nhân, thậm chí là không phải là vài tháng đâu mà rất là nhiều lần, có thể là vài năm. Thường á, là nó tồn tại ở người trưởng thành khỏe mạnh và không có biểu hiện bệnh nghiêm trọng, nhưng khi người đó già hoặc là mắc các cái bệnh làm suy giảm miễn dịch hoặc là có các cái can thiệp như là cái ghép nội tạng chẳng hạn, ví dụ như là HIV hay là AIDS hoặc là cái ghép nội tạng, thì các bạn biết là những người mà cái ghép nội tạng á, thì cái nội tạng đó là một cái cơ quan từ bên ngoài vào bên trong cơ thể, nên cái hệ miễn dịch của chúng ta nó sẽ tìm cách loại bỏ cái cơ quan lạ đó. Và đối với những cái trường hợp đó thì trong cái việc cấy ghép người ta phải cho bệnh nhân sử dụng các cái thuốc ức chế miễn dịch làm cho cái hệ miễn dịch của chúng ta suy giảm đi để mà loại bỏ, để không phải loại bỏ cái cơ quan cấy ghép đó. Thì những cái trường hợp đó như người già nè hoặc là những người suy giảm miễn dịch như vậy thì khi hệ miễn dịch của họ bị suy giảm thì lao nó ở dạng tiềm ẩn, nó sẽ phát triển trở lại và nó gây bệnh chứ không nhất thiết là chỉ trong vòng vài tháng mà thậm chí là có thể là vài năm. Còn trường hợp thứ hai á, là cơ thể của người khi nhiễm lao đã có miễn dịch suy giảm rồi, có thể là trong những trường hợp đó thì bệnh nhân sẽ tiến triển thành lao bệnh nặng và nghiêm trọng hơn. Thời gian ủ bệnh nó còn tùy thuộc vào cái hệ miễn dịch của mỗi người nữa.
Vâng, em cảm ơn ạ.
Yeah.
More questions?
Các bạn có câu hỏi gì nữa không?
Ở đây em thấy có cái bảng trong bảng nguy cơ ấy thì em có thấy là có bị suy thận mãn tính ấy, rồi có cái lọc máu ở thận là cái cơ chế là giống như bị immunocompromised hả cô?
Thì đa số là các cái trường hợp mà những người mà bị bệnh nền đó em, thì tất cả là hầu hết là các bạn các cái bệnh nhân đó người ta đã có cái miễn dịch suy giảm, nên là họ rất là dễ bị xâm nhiễm. Và khi các bạn nhớ là đối với trường hợp là vi khuẩn lao thì không phải là nó chỉ gây ra lao ở cái bộ phận là lao phổi. Nhiều người nghĩ là lao thì nó chỉ gây ở lao phổi, nhưng mà nó tấn công rất là nhiều cơ quan trong cơ thể. Nó có thể tấn công vào thận, tấn công vào vào dạ dày, vào màng não, gây viêm màng não, hoặc là vào xương, vào khớp, vân vân. Cho nên là khi mà cơ thể chúng ta bị suy giảm như vậy, bởi vì lao nó rất là dễ lây qua đường hô hấp, nên là khi mà cơ thể chúng ta bị suy giảm bởi các cái chức năng như vậy thì nó sẽ có nguy cơ mắc lao.
Vâng, em cảm ơn.
Yeah.
Okay, so we stop 5 minutes. Okay.
Okay.